Hello, ciao, ladies and gentlemen. Dear colleague, it's a pleasure and an honor to share with you my insight regarding the topic psoriasis comorbidity. I am Paolo Gisondi. I am a dermatologist in the University Hospital of Verona, Italy. The content keywords of my presentation will be to summarize the epidemiological prevalence of selected psoriasis comorbidity, to analyze the pathophysiological mechanism that connect psoriasis comorbidity, and to assess the clinical relevance of comorbidity in the selection of psoriasis treatment. I have a question for you. Which is your opinion on the relevance of comorbidity? Some of you could have this thought. Comorbidities are rare. Psoriasis is a disease of healthy people, and its association with comorbidity does not impact my clinical practice. Or comorbidities are quite frequent. However, I'm a dermatologist, so I'm focused mainly on the skin than comorbidity. Or comorbidity of psoriasis are frequent and clinically relevant. I routinely screen patients for comorbidities and take them into consideration. I would like to know your opinion about these possible three positions. This is a table summarizing the prevalence of comorbidity in patients with moderate to severe psoriasis. As you can see, the prevalence is high. We go from 11% of diabetes to 32% of metabolic syndrome to 48% of NAFLD, liver steatosis, nowadays we call MAFLD. Half of the patients, and also psoriatic arthritis, affect up to 30%. So these are numbers that account for our clinical practice. Which is the role of dermatologists in screening comorbidities? These are joint American Academy Dermatology National Psoriasis Foundation guidelines of care for the management of patients with psoriasis with awareness and detection of comorbidities. According to this indication, dermatologists should inform patients regarding this association, should screen patients regarding the risk of comorbidities, the measurement of age, weight, blood pressure, blood glucose, glycosylate, hemoglobin, lipid level, abdominal circumference, and put efforts aim at lifestyle modification, such as dietary change in obese patients, smoking cessation, exercise regimen. Another question for you. Which are the comorbidities that most impact your clinical practice? Metabolic comorbidities such as obesity, cardiovascular comorbidities such as coronary artery disease, psychological psychiatric comorbidities such as anxiety, depression, inflammatory comorbidities such as psoriatic arthritis, all of them or none of them. I put my effort in investigating the association between psoriasis and particularly metabolic comorbidity. Some years ago, we performed a study in Italy on the association of the metabolic syndrome, and we found that almost 30% of patients with moderate to severe psoriasis had metabolic syndrome, and even more patients, up 48 patients, had NAFLD. And also the risk of dyslipidemia and diabetes. And in more recent years are also investigating the risk of developing psoriatic arthritis, but I will come back later on this point. So this is a patient, Raffaele, 62 years old with diffuse psoriasis, and of course, associated with metabolic syndrome. So this is our peer in our clinical practice. I have a question for you. What would be your therapy for Raffaele? Topical treatment only, phototherapy, conventional systemics such as methotrexate, or biologics? In my mind, we have several elements to consider when selecting a psoriasis therapy, and part of these elements include comorbidities. Of course, other elements should be considered, but comorbidities are part of our strategy for selecting the therapy. And European guideline put our attention on the presence of diabetes metabolic syndrome, considering that some conventional systemic may not be the best choice. This is my approach to this consideration. You can see the systemic treatment, you can see the features of metabolic syndrome, and of course, conventional systemics may have some issues, some problems in this setting. Conversely, biologics have not. And for instance, for Raffaele, I selected IL-23p90 inhibitors, and this is the result of the control of psoriasis without causing problems on metabolic comorbidities, and without interaction with other drugs that Raffaele is taking. What are the mechanisms that link psoriasis to comorbidities? Common genetic background, common inflammatory pathways, common environmental risk factor, none of them, all of them. I thought about this question, and I think I can, of course, genetic could play a role. And this is a study investigating shared genetic risk factor and causal association between psoriasis and coronary artery disease. And the Venn diagram illustrates the number of shared and distinct genes involved in psoriasis and coronary artery disease. Notably, many of the shared genes are responsible for immune responses, including IL-6, NF-κB, IL-17, TNF. So, inflammation plays a role linking psoriasis inflammation to atherosclerosis, because the inflamed skin could release in the skin, but also in the systemic circulation, inflammatory mediators such as TNF, interferon, IL-1, IL-6, IL-17 that are connected also with atherosclerosis. The last question for you. Can comorbidities be prevented by treating psoriasis early and effectively? I don't know. It's an interesting hypothesis, but there is no data to support it. It's an interesting hypothesis, there is a rationale, and there is preliminary data to support it. I would vote for this response. There are some evidence. This is my contribution to the story that is, of course, ongoing story. But early in 2021, I noted that biologics could mitigate the risk of development of psoriatic arthritis in patients with psoriasis if compared to phototherapy. Phototherapy is only skin-directed treatment. Biologics may act in the skin, but also in the joints, in the entheses, in the synovium. So, in some way, could prevent, delay the development of PSA. And this is the number in action, the incidence rate of PSA in the two groups, biological DMARS versus phototherapy. And you can see that the dashed line, the probability of developing psoriatic arthritis is lower in those patients treated with biologic compared to phototherapy. Fortunately, my contribution is also consistent with other contribution appeared from 2021 more recently. Of course, we need other data. We need not only real-life data, but also prospective controlled data. But I think that is a very valuable scientific investigational hypothesis. So the conclusion is made by Dante, my cocker, spaniel cocker, and Dante, after listening my presentation, says comorbidity are convincing evidence that psoriasis is not just a skin disease, but extend behind the skin. And with this, I thank you very much for the attention, and I thank very much IPC, all the scientific committee, the president and the medical chief for opportunity to give my contribution for the initiative of the World Psoriasis Day. Ciao.